Hello and welcome to Spotlight on Migraine. I'm your host, Molly O'Brien. Today we're talking about the timing of migraine attacks, specifically waking up with a full-blown migraine headache. So why does this happen and what can we do about it? Well, to answer these questions and more, I'd like to introduce our guest, Dr. Christopher Gottschalk. Dr. Gottschalk is a professor and director of headache medicine, section chief of general neurology, and program director of headache medicine fellowship training at Yale University. He's a neurologist and a headache specialist. Thanks so much for being here.
It's absolutely my pleasure, Molly, and thanks for inviting me.
When we're talking about morning migraine attacks, what is that? What does that mean? What does that look like?
The simplest way to think about it is that migraine can occur at any time of the day, more or less. And as I think many of your viewers are familiar, it often follows a progression of symptoms over hours to days. So what part of a migraine are we talking about in any given situation matters. And in this case, we're saying sometimes people wake up and they've already reached pretty much full peak migraine headache pain. So that's not a fun way to wake up. It turns out that that's one of the most common times for migraine attacks to occur is first thing in the morning, at least based on the few studies that have asked that question. So there's something there apparently about sleep physiology and chemistry that makes this a little more likely to happen as the sun is coming up or whenever your morning time is. Um, and and the fact that it's already well developed at the time that you wake up suggests that the process had started and was brewing while you were asleep, which is what changes some of the considerations about how to deal with it. But I do think it's important to understand that people often use the term morning migraine, and the concern I have about that is that it suggests that it's a different problem, that there are people who have only that, or that it's a different kind of migraine. I don't think that's the case at all. I think it's just that you get taken by surprise by a headache that's well on its way as you wake up, as opposed to having some warning that what's ahead when it occurs in the middle of the day.
I guess it's best to understand the context of this conversation. When we're talking about a morning migraine attack, it means you're really getting smacked with that headache phase of the attack right when you wake up. Is that fair?
Yes.
Let's talk a little bit about what's happening in the brain and the body when we wake up with this morning migraine attack.
So the main point there, I think, again, is that what we now refer to as the prodromal phase of migraine, which is an enormously important concept, that a whole range of symptoms develop hours or even a day or two prior to the headache portion, are things that people become aware of while they're awake. So you might feel foggy headed or irritable or suddenly tired or craving weird food or very sensitive to light or sound for hours, and then a headache occurs. But if those things are happening while you're asleep, you just don't know about it. So whatever part of prodrome might have been happening in the sleep phase, you are missing all that, and then you wake up and there it is, the headache has fully developed. And that means it's a much more urgent situation in terms of treatment, because we know that it is extremely important to treat headache attacks, migraine attacks, as early as possible.
And if we aren't aware of our migraine prodrome, then it can be difficult to know. Maybe you're yawning a lot, but it's 7 or 8 o'clock at night and you just think you're ready for bed.
Right. Exactly.
So really understanding the migraine prodrome can be super beneficial. What seem to be some of the contributing factors that might lead to someone waking up with a morning attack? Do they differ a lot from if we get attacks other times in the day? Or does how we sleep, like maybe our neck gets out of position or grinding teeth? Are there any additional factors that might cause this or lead to it? Excuse me.
So no one has identified any factor like that clearly predicts having morning attacks. There are lots of those ideas that you've suggested, but I think, like many things that we used to call triggers, those are really associations that are as likely to be symptoms of migraine as they are actual causes. The idea that, for example, bruxism or grinding your teeth overnight makes sense, that that might make a morning attack more likely. But again, I don't think anyone has ever really found that people with migraine and bruxism are more likely to have morning attacks. That doesn't appear to be reliably true.
Okay.
And even sleep apnea. Yes, it's true that many people with untreated sleep apnea will talk about waking with some headache, but that tends to be a more tension type headache and not necessarily migraine. And it's most days until they get treated.
Hmm.
So whether having migraine and sleep apnea means it's more likely to have morning attacks, perhaps, but it's certainly not a very consistent feature.
When we're talking about, you mentioned sleep apnea, are there any factors out there or suggestions that an underlying medical issue might be a problem besides just the migraine?
Not that I'm aware of. I don't think we've identified any particular metabolic disorders or hormone imbalances that should be considered more in a patient who has morning migraine attacks.
Several people have said these types of attacks or the timing of this attack can be harder to treat. Can you talk a little bit about that? Does it just have to do with the timing, like you mentioned earlier? Are these just not as responsive? How does that work?
I think it's entirely about the timing. I don't think there's anything else magical about the fact that this occurs in the morning. And it's another example of the enormously important research that Dr. Burstein did 25 years ago now, showing that early treatment matters, not just because treating when it's mild is easier, but literally because as a migraine attack progresses, you shift from sensitization or irritation of the nerves on the outside of the head to actually activating nerves inside the nervous system, at which point most medicines can't get in there to do any good. Triptans don't get into the brain. So if you've already gotten past that magical point of central sensitization, then your triptans won't work. His research showed that if you've developed a clinical sign of central sensitization, a triptan goes from working 85% of the time to 15% of the time, just based on the timing.
Wow.
So I think that's the experience people are trying to understand is I woke up and I was so far along that my usual triptan or what have you just didn't cut it. Absolutely. That's why we need a bigger hammer, a faster hammer, a combination of things that will get the job done right at that point when you're on the verge of being in need of an ER or something else.
Kind of going off of what you said, you need a faster hammer, a bigger hammer, a combination of a hammer and screwdriver, whatever it is. What do you typically recommend, or what do you typically see as recommended to treat that full-blown migraine attack that people wake up with in the morning?
I absolutely advise people to explore non-oral treatments in that situation. We know that the speed of onset of the effect of injectable sumatriptan or a nasal formulation is so much faster, and that the peak strength of the medication in those forms is so much higher than a pill that you are far more likely to get a response even at that point. But if you take the example of middle of the day, oh, I'm getting some prodrome symptoms, or oh, I'm getting a little headachy, I think I'm on my way. You put a pill in your system then, and even if it does take an hour or so for the drug just to be absorbed into your system and get into your head, that could be fine. But when you've woken up with, I'm already at peak pain, you don't really have an hour or two to play with. If you don't get the job done quickly, you've missed the boat totally. So that's why an injection of a medication that literally hits its peak concentration in 5 minutes can make all the difference in the world.
Okay. And with that, non-oral, so we have the injection option. What about other options? Like there's nasal sprays out there now, there's nasal powders out there. Um, there's neuromodulation. Are any of those types of delivery methods, I guess, appropriate? And also, does the medication make a difference? So we have, there's all different kinds of medication options out there.
Very true. So this is also an example of a something I try to explain to patients often, which is that I think that if nothing else, the response to an injection of a triptan is the best yardstick that we have of what a good response can look like. So
Fair.
in that situation of morning headache, try this. Try it over a couple of attacks, and you'll get a sense of how well you can treat an attack in that situation. And then you can compare some of the other things you mentioned to say, could I get away with this other drug, this nasal formulation, et cetera? But hands down, the best guarantee of a response is going to be with an injection, something like that. So that's the yardstick idea. But yes, there are now several nasal formulations of triptans. They're clearly not all created equal. So the most recent addition to this group of nasal formulations, Tosymra, has an extra chemical in it that increases the absorption in the nasal passages so that a dose of Tosymra is more or less the same chemical absorption profile as what you get with an injection of about 4 milligrams of sumatriptan. That's a better pharmacokinetic profile than any of the other nasal triptans. So if I prescribe a nasal formulation, I typically prescribe that one. But again, it's about use patients trying some of these different options to see over time what's the most reliable one. And then I encourage patients to learn to judge where they are in the process. You wake up with a peak headache, you probably want to take the best possible option. You wake up with maybe I'm 50% of the way along, you might do fine with something else. So that's comparing triptan options. And then, yes, there is a nasal Gepant now, zavegepant. My reading of the information we have about that option is that it's not really any faster or a higher strength than the oral forms. Some people prefer the nasal form fine, but it doesn't appear that we have any information yet that says that's a better choice than some of the other oral agents in that situation. Neurostimulation could certainly be an option there, but most of those have a window of something like 45 minutes to an hour of treatment before you can expect a response. And my concern again would be that that's a little longer than we would like to have in that context.
Yeah. And you mentioned a couple different classes of medications. We're seeing coming to market DHE nasal spray and a DHE auto injector. Could those, if people are able to tolerate them, are those potential options because the delivery method is either an injection or a nasal spray?
Excellent question. Absolutely. I prescribe DHE all the time. I think it is one of the most important tools in our toolbox, and it is terribly underutilized for all kinds of reasons. But in this context, yes, the fact that you have a nasal formulation with good absorption and even better, an auto injectant form, which means maximal dose quickly, would make it an ideal choice for a morning attack. And it is also true about DHE that it has a much wider window in which it can work during a migraine attack. This issue of triptans work until a certain point in the attack and then it's really too late, that is not true of DHE. It does get into the brain. It has central penetration. So it's the drug that we use if you come into an ER with migraine for days or you've had an attack that lasted weeks or months. DHE still has the potential to work for just that reason. So that suggests that you'd have a lot more flexibility using DHE in the morning with a bad attack because it doesn't care as much about exactly when you jump in.
I love that. I love that description. It just doesn't care. It doesn't care when you use it. I'm curious how a migraine patient might be able to talk to their doctor about accessing treatment options for when they wake up with a full-blown migraine attack. Oftentimes, insurance is limiting to the different types of medication, the different ways that you take the medication, and then how many you can get. So, what might be a good way to approach talking to your doctor and be like, "Hey, triptans work for me orally, this, but I also would like something when I wake up with a headache."
I think that's pretty much the starting point, right? Is to for a patient who's as well informed as your suggestion, someone who's thought about, okay, I have a condition we call migraine, but it has many different flavors. I could have a slow, mild attack. I could have a rapid crash attack. I could have an attack in the morning. So, depending on how many of those varieties you experience and with what frequency, and that you've had the experience of, I wake with a headache like this, and the stuff that I use in the middle of the day just doesn't cut it. What are my options? Or I understand there are options that could work better. Absolutely. The other real obstacle that we face in that conversation is that some insurance policies, even now, will say, sorry, you get one triptan. And I will write a letter to them saying, apparently you don't know much about migraine, but there are different types of attacks, there are different levels of attacks, and this patient needs different formulations to manage different severities of headache.
Okay, that's great and helpful. So it could be just the migraine patient taking the knowledge that they have of their own body and the attacks that they experience, and then really trying to work with the doctor to see if they have insurance, if they don't have insurance, just if they can access this medication and try to make something happen so that their toolbox is more complete for their condition.
You got it.
Awesome. All right. So I want to shift gears a little bit. A lot of times, in a lot of cases, people enjoy caffeine, whether it's a cup of coffee or whatever it is, especially in the morning. Caffeine can be tricky with migraine. Do we know anything about whether caffeine may help, hinder, hurt when you wake up in that headache portion of a migraine attack? Or is it just kind of like, it depends on the person?
Unfortunately, it's mostly the last part. So I'm not aware that anybody's ever taken the time to look at whether or not adding caffeine for a bad headache first thing in the morning is any better than just using whatever other choice you have that works. In general, we know that caffeine can be a helpful additive to anti-inflammatory medicines for various kinds of pain, including mild to moderate headache. So it might be something that you add, but I certainly wouldn't think of it as the primary intervention. It's not, I don't think it's true that people get morning headaches because they're in caffeine withdrawal. Otherwise, that would be pretty much every day.
Yeah.
Um,
Good point.
it is true. It is true that if somebody has migraine and puts themselves into caffeine withdrawal, they're more likely to have a migraine type attack than somebody who doesn't have that history. Fine. But whether or not adding a cup of coffee to your triptan or whatever else you're taking when you wake with a bad headache would be even better, I think that's just trial and error. Now, I'll step aside there for a moment and say, on the other hand, what we have in the little bit of literature that we have about hypnic headache is this carryover idea that caffeine may be a good intervention there. I find that bizarre. The idea that you wake up at 2 in the morning with a headache and the thing that you should do is drink a cup of coffee or a Coke.
Yeah.
I suppose somewhere along the line, somebody said that that helped, and there you go. You have this story that won't let up. But I would not be able to get back to sleep after that. And I think depriving somebody of sleep is a lot worse than something else.
Our body needs rest. Does our body need caffeine? I don't know. That makes a lot of sense when you put it in that context. Is there a way to help people distinguish if this is a new attack that started while they were sleeping, the prodrome, maybe they missed it, versus maybe they were already experiencing migraine and in an attack the day before and their medication wore off? Is there a way to kind of figure that out?
I think that's, I mean, only to the extent that what you're talking about is a practice of mindfulness, right? I think it's about paying enough attention. And if this is something that comes up that you get some bad attacks in the morning, then I think you would do yourself a favor by paying a little extra attention. So write down what was yesterday really like. Oh, yeah, I felt queasy all day, or I kept asking people to turn the lights off, or whatever it was. Maybe that's really saying I was well on my way by the time I went to bed, and lo and behold. And then certainly I've had many patients who will say, I have this repeated problem that I'll have a migraine, I'll take my medication, I feel better, and the next morning I'm likely to wake up with a banger. And in that situation, I think my interpretation of that is the acute treatment on the first day worked, but not completely. You felt better, but it may have only gotten you 80% of the way there. And then all it took was overnight for that to build back up to 100%. So in those patients, I will often try things like, when you treat your headache on day one, when you go to bed that night, take what is essentially a chaser. Take a long acting triptan, maybe an anti inflammatory, even if you feel well, because there's a good chance that that will cut it off at the pass before the next morning. And that has often worked well. So I think there's room for some creative ideas like that.
I love that idea of a chaser. Maybe you feel better, maybe your treatment worked, but to prevent it coming back full blown, turning back into 100%, uh, uh, use other treatments at your disposal the night before. What do you think is an ideal toolbox for people? What options should people have, and maybe talk to the doctor about?
Terrific question. So, I mean, the good news is that at this point in history, we have more options for what goes in a toolbox and more information about how they work together or what the different possible purposes are than ever in history. So that's the great news. But I think that probably gets a little overwhelming for everybody because there are so many
Yeah.
choices. So I think on the one hand, I spend most of my time when I meet new patients talking about the goals of treatment of acute attacks, that I absolutely believe it's true that for almost every patient, we should be able to offer you something that will get rid of all your headache symptoms within a couple of hours with minimal or no chance of it coming back the next day. Those are the FDA mandated outcomes of an acute migraine treatment option. That's what it means to say that it works. And I'm always amazed that so few people know this or have ever heard that, like it's some kind of a secret. Um, but if you start with that, then the goal of the toolbox is that over time you'll learn that depending on how you feel right now, you need to reach for this tool or this combination of tools because it's more likely to get you there. And if you did one thing and it just didn't work, you have a backup to say, well, when I missed the ball a little bit, I can follow it up with that. So that idea that you're trying to tailor treatments to your own experience and that there should be options available when you miscalculated or something went different and it didn't quite work. That's the outcome you're after. And then getting there means some combination of multiple different types of medicine. I think that combination therapy should be the default
Yeah.
for treating attacks. Triptans are fabulous. NSAIDs do wonders, especially at high doses. Dopamine blocking agents like Reglan and Compazine are actually great headache medicines, and they improve the absorption of other medicines. So they do a lot. So learning that combining different mechanisms means probably a better outcome most of the time is a really important step. And now we even have a few proprietary options that combine a couple of drugs for you. Super. But knowing that you don't have to rely on just one kind of medicine or just one kind of treatment is important. And then there is that stratification idea that I need things that I can do when it's mild and I think I'm getting a headache. I'm in the middle of it, but I'm not terrible yet. I don't want it to get any worse. Or, it came on fast, or I woke up with it and I need the strongest thing I can reach for right now before it's too late. So levels of treatment matter. And now then we have the business of, besides medicines, there are neurostimulation options, which maybe you use when you think you're getting a headache, maybe you use in the mild phase with medicine or not. All of that adds some real flexibility. And I think we're also finally getting to the stage where we're looking at non-pharmacologic and even non-stimulation things like mindfulness practice, that practicing biofeedback when you think you're in prodrome might very well be an effective intervention. We're not quite sure yet, but recognizing that there's actually probably a much longer window at the lead in to a migraine than we used to think, I think will continue to add more and more options to people as they learn to recognize where they are.
As we wrap up here, Dr. Gottschalk, is there anything else that you think migraine patients should understand or know?
I would only say that whenever I talk about acute treatments and the options available, the biggest challenge I find is that most people settle for too little. I think that patients and doctors still have this notion that, well, if it takes the edge off, that's good. And I don't think that's true at all. I think we have lots of evidence that shows if you don't actually have the ability to extinguish an attack, things will get worse over time. But until you've tried this whole range of options and you've learned what a really good response to an acute treatment can mean, you just don't know.
Thank you so much for sharing all of your insight and expertise and knowledge with us today. I know this is going to be super beneficial to our audience. We really appreciate it.
I appreciate you saying that, and I very much appreciate the opportunity to be here. Good to see you.
It's good to see you too. It's been a while, so we're glad to have you back. And that wraps up this episode of Spotlight on Migraine. A big thank you to all of our followers. This podcast is made possible by supporters like you. You can make a tax-deductible donation today at migrainedisorders.org. I'm Molly O'Brien with Spotlight on Migraine. We'll see you next time.